So I have a slightly more straightforward talk, and hopefully we'll be able to get back on time here. I have nothing to disclose, but we will be talking about some off-label techniques, which I will definitely disclaim when I get to them. So we're talking about thoracic aortic aneurysms now, and specifically descending thoracic aneurysms. We'll talk quickly about the relevant anatomy, the epidemiology, the indications as far as we know for treating, and then we'll talk about some pitfalls in the endovascular era, and then what to do with the left subclavian artery. Here's the anatomy. We're talking really from the left subclavian artery down to the celiac artery. Just a little review of the spinal cord perfusion, which will be relevant later. The spinal cord gets most of its blood supply from radicular arteries throughout the lumbar and thoracic region. There is about 25% of the blood comes from the pelvis and hypogastric collaterals, and then a contribution also comes from the vertebral artery, which feeds collaterals to the anterior spinal artery and is an important vessel as well. So thoracic aneurysms are definitely less common than infrarenal AAAs. They are also less common than ascending aneurysms as well as arch aneurysms. They're not rare though. They about 6 to 10 cases per 100,000 person years is the stated incidence. And descending thoracic aneurysms make up about 35% of all thoracic aneurysms, coming behind the ascending. Thoracoabdominals are even less prevalent, although because they're so difficult to manage, there's definitely quite a few talks on them. A lot of them tend to be associated with dissection, which gives a prevalence of these aneurysms in a slightly younger patient population. And 10 to 19% of patients that present with these have a first-degree relative. If the patient is young and has no other risk factors, you should think about a collagen vascular disease. The natural history of thoracic aneurysms is not as well defined as an infrarenal AAA, where we have studies like the UK small aneurysm trial, which gives us a nice correlation between size and rupture rates. Really, a lot of our data just comes from longitudinal studies and registries. There was actually a longitudinal study that took place in the 1980s that showed that patients that are observed for thoracic aortic aneurysms, a large proportion of those go on to increase in rupture. But again, there's just a vague association with the sizes, and it's not well defined. The average size at rupture is 6.1 centimeters, and the quoted rupture rate is 12% at 6 centimeters. Given that there's no randomized data, there was a consensus statement, a multi-society statement, basically in 2010, that stated that aneurysms larger than 5.5 centimeters should be repaired, although you'll still occasionally read the 6 centimeter cutoff in some other sources. I would say with a 12% rupture rate at 6, that might be a little bit small though, or sorry, a little bit large for observing. Finally, that's really for asymptomatic aneurysms. These aneurysms can certainly cause pain during impending rupture. Arterial to arterial embolization is relatively common given the high shear stress in these aneurysms, and you can have compression of adjacent structures like this diagram of the bronchus being compressed. In 1950s through 70s, they pioneered work with doing these repairs open. A lot of times it involved bypass surgery in order to maintain distal perfusion. But over time, with the advent of TEVARs in the 1990s, we've largely gotten away from open repair due to a assumed higher mortality and morbidity rate. There's no level 1 evidence comparing the two, but open repairs that even at centers of excellence have a 3 to 5% mortality and a 5 to 8% paraplegia rate. Endovascular therapy is certainly not without risk, though. The risk of paraplegia is quoted anywhere from 2 to 4%, and stroke is also a major risk factor during TEVAR, with a quoted risk rate of 3 to 4%. Some series even have that as high as 8%. Keep in mind, those are comparable to undergoing a carotid endarterectomy, so it certainly needs to be part of your consent process if you're looking at repairing someone with TEVAR. To avoid strokes, there really is no magic recipe. Avoiding excess wire manipulation in the arch is important. There's been some suggestion that some of these strokes may be due to air embolism, and so de-airing has become a focus recently. And avoiding paraplegia is really a talk all of its own, but there's definitely some suggestion that revascularizing the left subclavian artery, if it's being covered, is important, and we'll talk about that a little more. Avoiding unnecessary coverage is certainly important, and if the patient's at high risk of paraplegia, considering a lumbar drain is definitely a good idea. And if you're going to use one, have a protocol. The anatomic factors of a thoracic aneurysm that make it amenable for treatment. First off, you need to make sure you have an appropriate diameter graft. If your quote-unquote neck is larger than 46, you're really not going to be able to get an endograft that can treat it. And due to the high shear stress in the thoracic aorta, you really need 2 centimeters of proximal and distal seal zone. That's opposed to 1.5 centimeters for infrarenal. Now some devices are even shorter, like a juxtarenal Z-fen. That 2 centimeters is important, and very frequently in order to get 2 centimeters, you end up having to land in zone 2 of the thoracic aorta, which means covering the left subclavian artery. Access site management is important, but in the interest of time, I think we'll skip this slide. So now, in terms of managing the left subclavian artery, about 20% of descending thoracic aneurysms require zone 2 coverage in order to get adequate seal. Initially, this is sort of swung back and forth in terms of management. The initial descriptions of covering the left subclavian artery were almost always paired with a carotid transposition or a carotid subclavian bypass. But eventually, looking at the trauma literature and the rupture literature, there were registries and reports that about 70% of patients that got their left subclavian covered developed no additional symptoms, and so people started routinely covering the left subclavian artery. Then there was a large institutional database report by Peterson et al. That showed a very high rate of posterior stroke and spinal cord ischemia in those patients that were not revascularized. But again, the number of patients he was really looking at that had issues with it was, I think, about 6 patients, so it wasn't a huge number of patients. Eventually, that led us to the Eurostar registry. The Eurostar registry was a voluntary, prospectively maintained database of 58 European institutions. The patients are very heterogeneous. Some of the patients got thoracic TEVAR devices for dissection. Other ones got it for aneurysms. But there were quite a few patients, 600 enrolled. And they also noted that there was a higher risk of spinal cord ischemia in patients that had their left subclavian covered without revascularization. They had about an 8% spinal cord ischemia rate in those patients, and none of the patients that had it revascularized actually had spinal cord ischemia. Based on this registry data, the SVS basically recommended that the patients all undergo revascularization if it's an elective case. The options for revascularization include the carotid to subclavian bypass, as we mentioned earlier. Other options include a chimney parallel graft repair. That's limited by gutter leaks, similar to what Dr. Maldonado was just talking about for the hypogastrics. Another option is actually in situ fenestration. This is clearly off-label, and one of the ways this is done is basically a laser fiber is put right up against the graft and used to perforate a hole in the graft in order to create a fenestration through the graft material. Here you have, they've actually already lasered through the graft, and they're now deploying a stent in order to get that seal. So that is a definitely off-label option, but does avoid that gutter problem. And then finally, to conclude, there are a number of investigational devices from virtually every company which is in the space right now, including Medtronic, Gore, Bolton, and Cook. This This is actually the Cook device, the TBE, which has a precannulated side portal, and this device is basically positioned at the level of the subclavian artery, and then either through the femoral approach or through a flossed approach through the arm, you go through the side portal and then deploy a flared stent in order to get seal in the subclavian. So those are the options to manage the left subclavian artery. I think what evidence we do have supports revascularizing it in an elective case. Thank you.